turn on the, okay, I'm sure everybody knows Dr. Halasa. If not, you want to just introduce yourself real quickly. We have a new, Dennis is a chiropractor, and he does a specialty of C1 something or other.
Yeah, I'm Dr. Halasa. I'm the founder of Chronic Disease Prevention Management Centers, and I'm trying to end up developing centers in every state. Hopefully, I'm working on that. And we manage all kinds of chronic disease across all medical specialties. It's a form of integrative medicine, but just we try to make it a title where the public and the mainstream medicine can understand the therapy that we are providing. So my background, I did some pain management work or clinical work for 4 to 5 years. And I graduated from overseas, from Libya. I passed my board exams, United States medical license exam. And I'm just more of entrepreneur, clinician, researcher, and trying to enjoy the life as the maximum I can. So that's what I'm doing. And hopefully you will enjoy the lecture of today. It's going to be very interesting because we will see that there's a lot of subclinical hypothyroidism that is leading a lot of, causing a lot of chronic diseases, back pain, constipation, fatigue, neuropathy. And I mean, I'm talking about back pain with spinal cord stenosis. And that's the interesting part of chronic hypothyroidism as the root cause for some of spinal epidural or spinal stenosis. And we're going to see all the mechanism how hypothyroidism led to spinal stenosis, and patients will complain with lower back pain and shooting and numbness and tingling and weakness in their legs. And most of the doctors on pain management, they think it's just spinal cord stenosis, and they start injecting steroids, and repeating injection of steroids may complicate the case. And we're going to learn that in the coming slide, and the reason why epidural steroid may lead to make the problem more worse. So can you see the slides? Can you hear me, guys?
Yes, yes.
Okay, okay. Let me turn it into, okay. My computer is slow. Okay. So Hashimoto thyroiditis, it's a chronic autoimmune thyroiditis caused primarily hypothyroidism due to cellular or humoral-mediated destruction of thyroid tissue. So the reason why you have destruction of the thyroid, it's because either you have Th1 dominant immune destruction of the thyroid, where you see the CD8 and cytotoxic cells are destroying the thyroid as an autoimmune disease, or you will see the other side, which is Th2 dominant autoimmune destruction of the thyroid, where you see antibodies are high. So there's two kinds of immune destruction, or two kinds of autoimmune thyroiditis. And we need to identify that, because if you want to manage the thyroiditis inflammation, then if it's Th1 dominant, then you want to shift it to Th2. And if it's Th2 dominant, you want to shift it to Th1. So knowing exactly the pathophysiology of the thyroidites, of Hashimoto thyroiditis, and you can do that by measuring the cytokine profile, see the interleukin-4, interferon gamma, and interleukin-7, and both sides of the aisle, whether it's Th1 dominant or Th2 dominant, you will see that there is hyper Th17 immune involved. And so that's why we're giving now low dose naltrexone to inhibit Th17. And that's one of the kind of, you can say, I would say it's the main treatment for thyroiditis, in addition to giving thyroxine, is to manage the autoimmune destruction of the thyroid, because you don't want the inflammation of the thyroid continuing. The reason why, because there is a high risk of this thyroiditis, whether it is cellular, especially the Th2 dominant autoimmune destruction. They may end up developing papillary carcinoma. And so the mainstream doctors, when they manage Hashimoto thyroiditis, they don't really care about the inflammation of the thyroid. So they don't give you anything anti-inflammatory or any immune modulator or anything like that. All they give you is giving you thyroxine as a replacement. And without knowing that the fact, if you leave the inflammation of thyroid continuing, it may lead to papillary carcinoma. So managing the inflammation is not really to, well, it's good to save as much of thyroid to produce natural thyroxine, so you can give less of thyroxine synthetic, but it's more of preventing from developing cancer, especially the Th2 dominant thyroiditis, where the antibodies are high. So most common cause of hypothyroidism is caused by Hashimoto thyroiditis. And female, it seems like there are more than male with this autoimmune destruction, and up to 10% of general population with increase with age. So there is a large increase in number of thyroiditis, even with if you compare it with years before now, there is some trend of increasing in the number of cases of Hashimoto thyroiditis. It could be because of all this contaminations, and which trigger those petrochemical contamination that we have, which may trigger autoimmune diseases in general. So we know that Hashimoto hacks up the thyroid gland and destroy the thyroid gland, and we will end up having low thyroxine and low body metabolism, general basic metabolism. So what's the risk factors? Genetic condition, Down syndrome, Turner syndrome, HLA, DR3, Graves' disease, they're all risk factor for developing Hashimoto thyroiditis. Stress, and I think that's one of the reasons why we see increased trend of Hashimoto thyroiditis, because the life that we're living, it's very stressful. With all this advancement that we have, but socially we are stressed, and most of the people, especially in, I'm not talking about the suburban, urban people, but I'm talking about the city people, where their life it's more stressful because of the work they're doing and their lifestyle, and working in the office without enough of exercising and enough of outdoor activities. Family history, so it has some genetic there. Gender, female is more, and high iodine consumption also. So we have two types of thyroiditis. It could be rubbery erythroid, progressing to hypothyroid fibrotic, and those one are the Th1 dominant. And then you have the atrophic hypothyroid or thyroid lymphoma. So those are two kinds of Hashimoto thyroiditis. Whether you will see them, they are having big rubbery thyroid, you can palpate them, and they are fibrotic, or you will see them that the thyroid is atrophy and small and shrinking. And the way that we can diagnose it is, ultrasound would help us to really see the thyroid and their consistency, and you can even detect the inflammation using ultrasound, and you can see they look in the ultrasound fibrotic or they atrophied, and that may give you some indication that the patient has hypothyroidism. But of course, we need to do the lab. That's the ultimate the lab, which is TSH, T3, T4, and then find out if the patient has low T4 especially, and high TSH. That means the patient is hypothyroid, and then you check the antibodies, and if they have high antibodies, then that is the diagnosis for Hashimoto thyroiditis. Cigarette smoking and infection, it can induce or can be a risk factor for Hashimoto thyroiditis. Okay, so what will be the signs and symptoms of hypothyroidism? Of course, you would have low general basic metabolism in the body. Everything is low. All the metabolism of your body is low. So that's mean you would have hair loss. You would have coarse dry hair. You have dry skin. You would have periorbital puffiness. Psychiatrically, with the patients, they will present depressed and fatigued because there is less metabolism going, less of serotonin and dopamine in the brain is the amount of it's going to be less in those patients, and so they will feel depressed and fatigued. Also, because the catabolism is slow or low, then you have the weight gain. They cannot burn the food, you cannot metabolize properly, so you have intolerance to cold. All the time they feel cold, hypothermia, and muscle cramps. Also, you will see the patients have slow heart rate, bradycardia. The circulation is slow, so you have pallor and delayed relaxation. I think that's one of the exam that we do when we start doing the knee reflex, and we'll see that the legs, when it's time to turn back, it's going to be slow. So the kicking is good for the reflex, but the relaxation is going to be slow, and that's part of the hypothyroidism. And our hypothyroidism signs. Other thing that we see in a lot of patients with hypothyroidism, they will present with constipation, menstrual abnormality, whether it's going to be amenorrhea or menorrhagia, and then they will have high prolactin, so they may have also galactorrhea. So hypothyroidism can lead to high prolactin, and also can lead to low testosterone. And all of that can lead to prolactin high and galactorrhea. So when you do your lab, do all the TSH, T3, T4, and then the antibodies, and also do the also do prolactin. So Hashimoto thyroiditis, as I said, there is immune imbalance. Defective in the T suppressors, which are the T regulatory cells. They're being defected, and when you have defection of the T regulatory cells, then your immune system start eating itself and destroying your own organs or tissue. And so you would have either it's going to be cell-mediated destruction of thyroid follicles, which is Th1 dominant, or Th2 dominant, which is going to be cell-mediated production of antibodies against thyroglobulin or thyroid peroxidase. And then you would have those antibodies. We need to measure it as a diagnosis for Hashimoto thyroiditis. You will see that they are high. Thyroid stimulating hormone antibodies also, you will see that they are high. And also antibodies against sodium iodine cotransporters or cell porters. So those are the diagnosis that you're going to do, is check those autoantibodies against thyroglobulin, against thyroid peroxidase enzyme, against thyroid stimulating hormone receptors, and against the sodium iodine porters. But the main ones are anti-thyroglobulin, anti-peroxidase antibodies, and anti-TSH receptor antibodies. Okay, and eventually the patient will have low T4, and they will have high TSH, and a combination of antibodies along with the high TSH and low T4, that's a diagnosis. So high TSH, low T4, anti-thyroid peroxidase elevated, and thyroglobulin antibodies. And the treatment, well, the mainstream doctors, how they treat them, you go to endocrinologists, they just give you thyroxine. I think they give 2 milligram per kg of microgram, 2 microgram per kg. I myself, I removed all my thyroid because I had papillary carcinoma. My father has it, and I'm taking 200 microgram of thyroxine every day. And I do recommend giving synthetic. Don't do the natural, because the natural is not reliable. They don't give you steady thyroxine that's reliable amount that will suppress the TSH. And patients taking armored thyroid, most of the case they have, or they will be suffering from chronic subclinical hypothyroidism. And that can lead to many complications. And the main complications, they end up having constipation, chronic ones, which may develop into diverticulitis or diverticulosis. And they may even have mixed edema deposit into the wall of the colon. And that leads to colon dilatation and even volvulus, which is twisting, which requires surgery. So I do recommend not to prescribe armored thyroid for your patient. Use levothyroxine and 2 microgram per kg for those patients. And then will be different from as integrative doctor or as chronic disease prevention management doctors, CDP, MCS. We also need to manage the thyroiditis itself, the inflammation, and that would distinguish you from the endocrinologist, because the inflammation can lead to papillary carcinoma. So you need to give them low dose naltrexone and polyphenols. So polyphenols, curcumin, quercetin, ECGC. Make sure you optimize the health of the patient metabolically, redox, and immune if it's possible. Also, if you can come up exactly what is this thyroiditis, is it Th1 or Th2 dominant? Can you modulate it and shift it? And you can use peptide for that. So if you have Th1 dominant, you can use thymosin beta or erythropoietin peptide. If it's 2H2 dominant, then you can use thymosin alpha or interferon gamma, just subcutaneous injections. But it's good to balance it. Don't give steroids for those patients. It's not worth it. But give some immune modulators. If it's and peptides and polyphenols will be enough, along with low dose naltrexone. You can start with 1 milligram of naltrexone. So there is cases that where subclinical undiagnosed hypothyroidism for a long period of time, they will deposit pseudomyxedema in their colon, which leads to pressure in their autonomic nervous system. And then they will have some sort of neuropathy in their colon, and they will have functional constipation, and chronic functional constipation can lead to diverticulosis because of all the pressure. And then it can lead to those deposits of pseudomyxedema, so just soft tissue and fat tissue depositing to the wall of the colon. It can lead to twisting of the colon and volvulus of the colon, which require surgical removal. So it's very, very serious that we need to check patients, especially if they present with long-term constipation. You have to put in your mind, this could be possible hyperthyroidism, subclinical hyperthyroidism. And I will recommend doing TSH-T4 if patients have constipation that is resistant to all the traditional treatment for constipation, like laxative and stimulus and all that stuff. And they say, well, I did all of this and it's not working, I'm still constipated. Then you need to consider that this patient, they may have hypothyroidism, and checking the TH3, TH4, and especially TH4, TSH is very critical at those, because I have experienced a patient, or I have a patient, I consult with them, and he was having hypothyroidism for a long period of time, and he was taking armored thyroid, which is unviable, and he present with chronic constipation, horrible constipation, that he used everything out there, it's not working, it's not helping. And also he had lower back pain as well, and he's been diagnosed with spinal cord stenosis, and he has numbness and tingling and shooting, the typical spinal cord stenosis. And the doctors, they failed to know exactly why he has this neuropathy, peripheral neuropathy, both upper and lower, and in addition to spinal cord stenosis and weakness and of his lower limbs. And when they did the MRI, you can see that there's clear stenosis, and he tried all the steroid injections, epidural injections, The reality is that the epidural injections may make things more complicated for those patients. Why? Because repeating epidural steroid injections can lead to epidural lipomatosis, which is depositing of the fat around the spinal cord and causing more and more compression of the spinal cord. And hypothyroidism can lead to also epidural lipomatosis and spinal cord stenosis. So because that you have low thyroxine, then you have low catabolism, then you have the tissue is depositing around the spinal cord is not being catabolized properly because you have low thyroxine, you have low basic metabolic rate. And that itself is causing the pressure on the spinal cord. So that's the reason, you know, if this patient goes to the pain management, they consider it as spinal cord stenosis, they start injecting the steroids without looking at the root cause. And that's where that makes you as integrative doctor here different from the pain management and mainstream neurologist. You will be looking, okay, so he has spinal cord stenosis, but why he has spinal cord stenosis? The neurologist, he doesn't really care about it. He doesn't even answer that question or ask those questions, nor the pain management. What they do, they just give them the injections of the pain or give them narcotics and move forward. But you need, as a root cause, as an integrative, as CDP, MCS physician, no, I want to know why he has that. And he has it because he has hypothyroidism. So you will be checking his T3, T4, and TSH, and you will find out that he has hypothyroidism. And possibly, if you just put him on thyroxine, those epidural lipomatosis, it may reverse. So I still, because those cases are very rare, so I'm expecting there will be some reversal, but I'm not expecting 100% reversal because there will be some mechanical already damage happen because of the mechanical pressure. But it's the first thing to do is to manage the thyroid and not injecting steroids into the epidural, because repeating injection of steroids can lead to epidural lipomatosis and may complicate the whole condition. So again, severe hypothyroidism, they may present what we call the myxedema pseudovolvulus, which is depositing those soft tissue and fat tissue into the wall of the colon, and then they end up twisting, and that require surgical intervention. Also, the same patient that I was consulting, he also has gout, okay? And so, you know, if you get gout, you say, oh, he has a problem with either overproduction of uric acid, or he has problem with secreting of uric acid, either way, right? And most of the time is overproduction of uric acid, and you recommend them to eat low meat, low protein, as much as you can. But the reality is that his gout is not primary. It was a secondary to hypothyroidism. So the hypothyroidism, low metabolism can cause decrease in the glomerular filtration of the uric acid and can lead to gout. So it's a secondary. So, and in fact, that allopurinol can make things more worse for those patients. And I think because why allopurinol can decrease the thyroxine production, it interfere with thyroxine production of thyroid. So they give them allopurinol, which makes the thyroid even less thyroid. It makes the hypothyroidism more worse. And so I think it's better if we look for the root cause, and knowing that this gout is secondary, not primary. So you don't manage it with allopurinol, you manage it with giving thyroxine. And once you give the thyroxine, this will improve the glomerular filtration rate, and this will eventually lead to managing the whole condition, and you don't need to really, you don't need to put all this.
US and Texas migrants. Mexico blames border
somebody's talking
in the US for the Texas migrant deaths.
Can you mute, please? Okay.
US crisis? Yeah. Because they think they can just sneak in, and the coyotes are.
Dr. William?
That's Olivia.
Okay.
So this patient, he has been recommended for a long period of time not to eat steak and meat and all that stuff, and he was being managed as primary gout. And I mean, that's just like half of his life is not eating meat, and he likes meat. So it's something that you really interfere with his quality of life by asking him not to eat meat. And the treatment really it's to fix the thyroid, not to decrease the production of uric acid. In fact, when they give, he was taking allopurinol, it makes even the hypothyroidism worse because it interferes with thyroxine production. So this is what we call when the treatment makes things more worse. And you think you're treating it, but in fact you're not. You're actually making the whole condition more worse. And that's the reason, as integrative doctors, we look for the cause. We try to find out, and we try to screen secondary conditions before we treat it as a primary. And that's very important as integrative doctors. First of all, you have to screen whether this condition, any condition, is it secondary and reversible, or is it primary? And all the time you start thinking about secondary first. And then if you exclude all the secondary and you did all the lab and everything is optimized, then you may consider the condition is primary, it's genetic, and then you can fix it. As if it's primary gout, then yes, you give them allopurinol and give them all that. But try the best to find out the root cause and try to treat the condition as secondary first. And if you exclude everything, then you start thinking it's primary. But don't think about the condition as primary. So if this patient, he present to internist as constipation, they start treating him with laxative and all that stuff without looking for the root cause of the constipation. If he goes to the neurologist, they start treating him with all those injections and giving him narcotics, which makes his constipation even more worse. And really, his treatment, it's $20 monthly of thyroxine. That's how much it costs. And doing all those injections was useless, and those injections cost almost $1,000 per shot for the Medicare or Medicaid. So we can be more efficient, more effective in our practice in medicine as integrative doctor, as a chronic disease prevention and management doctor. And we can save a lot of waste and money. As you see that in the United States, we have the highest expenses of the medicine per capita, but the efficiency and efficacy is lower than other countries. And part of it is the system, insurance and all that, but also part of it is
Dr. Halasa?
can use the whole
Dr. Patel.
Treatment or the whole.
Dr. Halasa, we're having a hard time hearing you.
Can you hear me now?
It's better, yeah.
Okay. So, yeah, Dr. Patel, do you have a question?
Yeah, I have a question, because there are some patients, those who don't have a problem in defecating, but then they have a severe pain after they defecate. And what is the explanation for that?
Well, you need to screen if they have proctitis, which is inflammation of the rectum. That's one of the causes.
It's not that. So
yes. So that requires some differential diagnosis, and then if you cannot figure it out just by clinical, then I think it's colonoscopy will be indicated here. But hemorrhoids.
Colonoscopy was done.
What is that?
Colonoscopy was done. Yeah, and it was normal.
Right.
And then the GI guy gave Linzess, that's a new medication, and patient says that has helped her pain for that. So I don't know how and for what reason
How the mechanism? Do you know that it's new drug because it's a commercial drug?
Right.
How it works? Do you know the mechanism of action of the drug itself they give it? Maybe that will give us some reason why. Are you with me there?
Yeah. They usually try to give it in patients with irritable bowel syndrome.
Okay,
IBS.
so I mean, he has any trauma, anything? I mean, you have to look for the history because.
No, this is almost a 86 years old lady.
Right.
And there is no, she was a professor. There is no history of trauma, but I think it is probably the degenerative disorder of some kind. So, an earlier part, there is probably a neuropathic pain that has helped.
Yeah. So that neuropathic pain, is it secondary to what? It could be that she experienced trauma before, and then that may develop.
She's a patient with exquisite food allergies, so I'm treating her for food allergy.
Okay.
She had a constipation, so she
has allergies, right?
Yeah.
Histamine, all that stuff. So possibly that can cause some neuropathy when you have too much of Th2 and you have too much of substance P and histamine, all that stuff. So they may have, and you said that she has irritable bowel syndrome, right? IBS, right?
Well, that's what you know, when they don't find anything, that's what they say.
IBS is form of complex regional pain syndrome. In other words, it's like migraine. Sometimes we consider as complex regional pain syndrome. It's sympathetic with pain fibers connected, and you have this vicious circle. So, and pain in the colon must, if it happened, it's happened in this somatic sensory, not in the autonomic. In other words, the lower part of the anus are the more sensitive part than the whole part of the colon. But I mean, there is no hemorrhoid or anything like that, no history of trauma, anything. But you may explain it with irritable bowel syndrome, possibly. But we need to look and if that irritable bowel syndrome is leading some sort of proctitis, inflammation of the rectum, because of the sympathetic overactivities there. It may develop, the pain and sympathetic overactivity can lead to inflammation and can lead to some sort of neuropathy and pain. But we will need to look and see if there's any publication that explain.
Thank you.
Yeah. So this is a picture of spinal cord stenosis, lipomatosis, epidural lipomatosis caused by hypothyroidism. And you will see that the spinal cord is surrounded by this soft tissue of fat and connective tissue. And we're hoping that when the patient will be receiving his thyroxine, that this will be reversed at least partially. And that will give some relief in the pressure of the spinal cord. I mean, this can lead to cauda but the patient that I am consulting, he doesn't have any rectal or urinary bladder incontinence, so we can say it's just the spinal cord stenosis. But this is how they look, and they can MRI. And so the patient that I'm consulting is 70 years old patient, present with history of intermittent lower back pain. So he doesn't, when a patient with hyperthyroidism or low thyroid, they don't really present with low thyroid. They present with lower back pain if they're, very
Dr. Halasa.
Yes, can you hear me now?
Yeah, when you lean back, we can't
lean down,
you.
okay. So a shade with numbness of the lower extremities. He's also complaining of severe constipation. And resolved by all the remedies that we're doing for constipation and even medication. He has extremities numbness, upper and lower, weakness, body cramps, intermittent postural dizziness, and possibly because that neuropathy, autonomic neuropathy developed as secondary to hyperthyroidism. And why? Because this myxedema, it's not just depositing under his skin or under his eyelids. It actually deposits on all the tissue of the body, including the neurons. And then the neurons, whether it is, in this case, autonomic neurons, which is the vagus nerve, they can be compressed by this soft tissue and those myxedema, and they will be presented as neuropathy. And autonomic neuropathy can lead to blood pressure variation. So he has blood pressure variations. He's complaining that when he stands up, he has some dizziness, and his blood pressure, sometimes it's high, sometimes it's low. So that is indication that he has severe autonomic neuropathy. He's been diagnosed with Hashimoto thyroiditis, but he was on Armour thyroid, 2 gram, and then he was on 65 milligram of levothyroxine, but he's not taking it in regular, so religiously. He was taking more Armour thyroid. And so Armour thyroid does not give them that reliable dose or level of thyroxine that the body needs. So he also has history of, or being diagnosed with spinal cord stenosis, with history of steroid injections, and the steroid injection gave him short relief, but then he started having it again. He's been diagnosed with diverticulosis or diverticulosis. He was on special diet and softener, but it's not working. It's constipation. It's not being relieved by all those relaxative and softeners and diet. On lab investigation, we find out that because of the constipation, doctors and myself, we thought, there's maybe something with cancer. Maybe it's obstructive. And the reality is that he doesn't have the signs of obstructive constipation, where you will see that the bowel sounds are increased, but actually he has functional constipation more so. But still, we thought there must be some sort of obstruction or something. So let's just go ahead and do some cancer markers workup. And we asked for C19, and it was high, but it's high for euthyroid patients. So for you and me as euthyroid, it's high and maybe indicate that there is some hidden cancer. But for patient with hypothyroidism, and they have high C19, it's normal for them. So this is the tricky thing that we need to learn. And you learn this from clinic. You don't learn it from the books. And the books, they say, okay, this is the normal range and that's it. But it's normal range for euthyroid, but for hypothyroid, it's not the normal range. You will see that their C19 is high, but it's normal for hypothyroid patient. And also the CEA, which is the carcinoma embryonic antigen, it was high, but it's high for euthyroid patient, for normal patient, but for hypothyroid, it was normal for him. And that's something you learn from clinical, you don't learn it from, so I think we diagnosed him as chronic complicated hypothyroidism, Hashimoto thyroiditis, and all his problem, whether the constipation, the spinal cord stenosis, the numbness and the tingling and all that stuff, it's due to the myxedema depositing on those tissues, and it's causing all this complication that the patient is presenting. And I think the management here is to normalize his thyroxine. And we did that, and we start giving him thyroxine. I think he's start feeling better. But again, it takes time for reversing partially all those myxedematous tissue that's being deposited in his colon, his spinal cord, and all over his body, around his neurons. We're hoping that all of this will be reversed, at least partially. And then we will think about how to further manage the patient if there's anything left from those complications of hypothyroidism, which is this myxedema, the soft tissue that's depositing and interfering with the function of the organs. Investigation and treatment. So again, we TSH, T3, T4, we ordered anti-TPO, and it was high. Antithyroglobulin was high. Uric acid was high. The CEA and CI19 was high. Again, it's high, normal for the hypothyroid. Testosterone was low. So those patients with hypothyroidism, they don't even produce enough of testosterone. So they will have male menopause, and they will have this cold feeling and sweating at night and low performance. And root cause here, we need to consider thyroxine first, fix it before you give them testosterone. But if he's in rush and he wants to perform, then you can give them both at the same time. I prefer normalizing his thyroxine, and hopefully testosterone production will return back to normal. And we order all the central and peripheral 6 hormones. I ordered interleukin 6, interleukin 7. I did not get the results out of that. I know he has low vitamin D, and we give him vitamin D supplement. The cod liver oil will be the best. And he has an MRI, and I think there is stenosis, and the stenosis is epidural lipomatosis. And the treatment that we offer him is levothyroxine, 2 micrograms, 2 microgram per kg. I think he's around 100 kilograms, so it's 200. It's a good thing for him. So this is Hashimoto thyroiditis. I think we learned something new about the complications, and also about a patient with high cancer markers, although it's normal for them. So some people or some docs will see those high cancer markers and say, oh gosh, he has cancer now. And they start doing all those investigations and all that stuff. And you can do them, but it's going to be kind of a waste of money and effort. But we did the PET scan, by the way, just to make sure everything is clear, and the ESC is clear from any cancer. And this cancer markers is just because he is in hypothyroid status, and that's the reason why he has high cancer markers, which is high for normal, but normal for hypothyroid patient. I think I'm done with the lecture, and if there's any question, go ahead.
Okay,
any questions?
Dr. Halasa? Yeah. Anybody have any questions? In the chat, Dr. Irwine says many practices use iodine for thyroiditis. You know, we have that iodinophobia as doctors. What's your take on that?
Well, if you see the risk factor here is too much of iodine is not, I mean, if you do it in a normal range, yes, but too much of it, according to what we learned today, it can induce Hashimoto thyroiditis. So giving it in the normal dose, I think it's good. And the salt we are eating are all iodinized. Is that enough? Yeah, I think it's enough. But if you want to add extra thing, just add it for certain patients who you think that they need it. That's my perspective.
Okay, what dose would you use?
I don't have it in my mind. What do you think?
We usually use a micro doses, 150 to 225 micrograms.
And you're giving it to all the patients, or certain patients who you think they are low thyroid?
Ones who sort of present with nutrient deficiencies.
Right.
Usually it's iodine and selenium, or
I mean, you're doing it after lab results, or just because you feel that he needs it in a given time?
I kind of I put together a nutrient panel that had iodine and selenium in it, but it was very expensive. It was like almost $600, so it was kind of impractical, cash price. So I kind of do it by exclusion.
Right.
And there are, I don't know if you want me to go on. So there are usually a number of root causes for the immune function to sort of go haywire. Gluten is an extreme. Usually these patients are extremely sensitive to gluten, and gluten in the diet can kick off and worsen the thyroid the thyroid antibody response. Certain types of infections can kick it off. herpes, and it's all of its forms, anywhere from chickenpox all the way to shingles, hepatitis A and B, Lyme disease, there's my low pregnenolone levels, heavy metal exposure can do it, there is, and food sensitivities can also do it.
So when you do detox, do you think that detox may lead to some depletion of iodine, and then adding iodine will be a good idea? Is that something you may consider?
I don't do it. I don't do it routinely, but like I said, if we rule out all of these things that we've just mentioned,
right.
Then also infections. H. pylori,
right,
is a culprit. Lyme disease, herpes, Epstein-Barr. That's the key. That's the big one actually, and I missed that. Epstein-Barr mono is a big one, and food poisoning.
My question is that when you do the treatment for detox, like doing IV, EDTA, and all that stuff, don't you think that some of those minerals will also be washed away, and then a replacement of minerals, including iodine, is necessary for those patients after doing detox?
Detox does not cause depletion of iodine. Is that
okay?
This is a question I need to know from you.
Yeah, you know what, I didn't hear 3/4 of that. So
okay, so when we do detox, right, EDTA or whatever detox we give to the patients originally, right, and we do IV and all that stuff, then we also, after that, we try to give them some Myers cocktail and mineral supplement, because we think that when we start washing out all those toxins and heavy metals, some of those minerals also will be washed out, the functional essential ones. And it's good to have some Myers cocktail after that, a poly-MVA. Do you think also iodine is necessary to add in the patient with post-detox?
I don't have a good answer for you on that one. So I'm going to defer that to you.
I'm asking to learn from you now, because I think you're doing a lot of detox, and after that you're doing some lab, and we know that there's some depletion of minerals because of detox, part of the side effects of doing too much of detox or doing even regular detox. It's good to have Myers cocktail after doing detox to make sure you replenish any washing out of essential minerals. The question is that, have anybody here measure elements and find out if there is a deficiency of iodine after we're doing the IV, EDTA, and all this detox? Anybody here have experience, have done lab after doing EDTA and detox, and what the lab shows regarding the minerals and the vitamins? No? Okay, I think it's something we need to practice it, possibly if you're doing detox here in the clinic, in your clinic. Can you do lab after run lab for minerals, and then we can learn from you if there's any effect on the minerals, and especially with iodine.
Yeah. Again, you're very garbled. I can barely hear you.
But you got my point, right? No.
Yeah. Mm-hmm.
Okay.
So, do you mind if I jump in and just add a couple of points?
Yes. Yes.
Okay. So it appears that part of the issue with the immune system going down is our immune system. Our cells get fooled into thinking that they have the adequate nutrients, particularly iodine and selenium, when they don't. So what happens is that we get we have here what I call the root causes of your autoimmune thyroid disease. And the first is your gastrointestinal immune thyroid connection, and that would be your gluten sensitivity and your so-called leaky gut. Also, there are a number of foodstuffs that are known as goitrogens. These are foods that will slow the thyroid down, and these are the ones that we attribute especially to postmenopausal women that are good for them. It's good for the menopausal symptoms, but it's bad for the thyroid. These are things like broccoli, cauliflower, kale, strawberry, spinach, and soy, and peaches, among others. These are what are known as goitrogens, and goitrogens will slow the thyroid down. Now, are you going to die if you have a spinach salad? Obviously not, but it's not, every little bit helps. Then we have the heavy metal exposure, and we know about glyphosate, PCBs, and all sorts of toxins that the body, the thyroid thinks it has its adequate nutrients, particularly iodine, when it is not. One of the big Hashimoto thyroiditis crises occurred in the early 1950s, and it was a direct result of two actions in the late 1940s. In 1947, the FDA declared that iodine was a toxin. There were two scientists in Berkeley, California, did some experiments on radioactive iodine, and then extrapolated the results to food grade iodine, and convinced the FDA to remove iodine from the food supply in 60 major US cities. At the same time, fluoride was put in the water supply to protect against tooth decay. Well, fluoride and iodine are in the same, in the periodic table, are in the same chemical category as halides, and our bodies thought that the fluoride was iodine until it realized that it wasn't, and it sent out the cavalry, which is our immune system, to remove the fluoride, from the body. And by 1952, there were all over the United States major Hashimoto's autoimmune thyroid outbreaks. It was of epidemic portion. So again, as we see today, nobody in charge takes blame for their idiocies. So instead of putting things back the way they were, the FDA sent out a call to arms, and they decided that Americans eat too much sugar and salt, and so to put the iodine back into the food supply, they picked salt. So that's where iodinized salt came from. It could have been an iodinized sugar, but that's the reason there's such a thing as iodinized salt. Heavy metal the toxicity, and it causes all of these kinds of diseases, is another cause. Mercury, perchlorate, nitrates. I actually have some patients who eat a lot of sushi and have very high mercury levels. There's not a real good remedy for removing heavy metal toxins. There's chelation, but to try to avoid it is nearly impossible. HEPA filters to clean the air, water filters. Fish with lower mercury levels are salmon versus tuna. You avoid processed and cured meats, and use organic skin products. And we've had Dr. Chandler on a couple of times with as the biological dentist. Liver detoxification, Dr. Halasa, this is your expertise here. You probably have a better protocol than I do, but this is kind of what we use. We like IV glutathione, and then it's sort of precursor N-acetylcysteine, or a liposomal glutathione, milk thistle, and IV vitamin C. The molecular mimicry caused by infectious agents, this is what I couldn't remember before. So herpes simplex 1 and 2, Epstein-Barr, food poisoning, Yersinia, hepatitis C, H. pylori, and Lyme disease. It wasn't off the top of my mind. To look for it, you get blood cultures, you get for hepatitis or herpes, hepatitis, H. pylori, and Epstein-Barr, and stool cultures, you can get H. pylori, Yersinia, and Lyme disease. Okay, viral infections, this is a treatment protocol. I'm not going to go through all of these, but these are the root causes of autoimmune thyroid disease. The last thing I want to leave you with is, let me find it. The last thing I want to leave you with is some of the one of the remedies that I mentioned in your group last week, Dr. Halasa. So we like plant sterolins. These are the fat from plants. They're supplements. There's two that we like. Brand names. One is Magicare, and there's lots of Magicares. I like the one by Thorne. We use it twice a day, and they act like Pac-Man. They actually go through the bloodstream and sort of phagocytize or gobble up the thyroid antibodies. You will get, if the patients use them, you will get a predictable decrease in thyroid antibody load by 50% per year. Now, on average, a patient will come in with a TPO or an antithyroid globulin at 200 to 400. So if let's say it's 200, so in 1 year it'll be 100, in 2 years it'll be 50, in 3 years it'll be 25, depending on the scale that you use. So that's a long time, but right now that's one is as best that I have found. If you use the low dose naltrexone with it, we get a little bit better result. But at least we're doing something, and we're actually reducing the antibody load. We also have used I've used the natural thyroids. I found that about the synthetic thyroids work about 70% of the time, but about 30% of the patients, it doesn't seem to work on them, and they feel better on the natural T3 and T4. We try to keep the, what else? We try to keep the TSH between 0.8 and 2.0 for the autoimmune patients. And we'd like the free T3 in the upper third of the sort of normal scale, about 3.4 to 4.2. We also look at reverse T3. I use that as a cortisol or stress hormone marker. The gold standard is the 4-point saliva test, but again, it's $250. This is what it is. You spit in the tube 4 times a day, and you get a graph that looks like this. This is normal. This is not normal. This is somebody who's got a lot of cortisol. And then this is somebody who's got, this was the same patient 6 months later after we were treating him, quite a bit better. And then this is somebody who's kind of got no stress hormone at all. So that, you know, we like the anti-inflammatory diet. We like the gluten-free. And I tell my patients it's a Judge Judy deal. You're either going to do it or you're not. It's a yes or a no. Not a little bit. I did it 80%. I did it 90%. Either it's a yes or a no. And they do feel a lot better on it. I don't know anybody who doesn't feel better, you know, not eating gluten. There's a few people it doesn't seem to affect, but pretty rare. And so I just like, those are some of the things that we do. I don't use a whole lot of iodine when we do. It's when we went through all of the other, like I said, root causes. If we've ruled all of them out, then we'll add in some iodine and selenium. There's a lot of supplement companies that'll make them. We use a low dose. The RDA the amount of iodine necessary daily is 12.5 milligrams. We use 150 to 225 micrograms, a homeopathic dose, and that kind of just seems to stimulate the system. That seems to be enough, at least in my experience. But other than that, thank you. Thank you for letting me rant.
Well, let me add something here. I mean, detoxing
is part of our management for any kind of inflammation with autoimmune diseases. And when you do detoxing, especially with EDTA and all that stuff, we consider that part of it, it's going to wash out minerals and vitamins, essential ones. And so after doing detoxing, it will be good if you do Myers cocktail, poly-MVA, some iodine as part of the management. But according to NIH, excessive iodine intake is not good. It can trigger autoimmune diseases. And also, deficiency of iodine can lead to autoimmune disease. So we really need to optimize the level and normalizing it, not doing too much and not doing making sure they're not deficient. But I would recommend, after detoxing the body and doing all the detoxification treatment, is to give some sort of poly-MVA minerals and part of it iodine as possible. That, you know, with all this detoxing, you're washing out those essential minerals and you're replacing it and replenishing it. There's a question that Dr. Patel about pain after a defecation. The patient, as we learned, that she has irritable bowel syndrome. And yes, irritable bowel syndrome, it's a form of complex regional pain syndrome, like migraine also is complex. So there is some pathetic connected with the pain fibers, and it's overactive there, and they have constipation, diarrhea, and all that stuff. So they have some problem with their autonomic nervous system, along with pain connected there. And yes, IBS leads to proctitis, which inflammation of the rectum, and can lead to pain during defecation, right? Is it called dyschezia or something? Pain defecation. I think it's called dyschezia or something. But that's the pain during defecation. So it's part of her IBS, irritable bowel syndrome. I think what Dr. William here is telling us, part of managing autoimmune disease is to get rid from all those heavy metals and toxins, and the management of giving glutathione and NAC and possibly IV EDTA, zeolite, activated charcoal, whatever you can do, although we don't have enough evidence that we are doing much of cleaning of the toxins, and it's better to prevent exposure to the toxins than managing it and cleaning it from the body by giving all those consultations about healthy diet and avoiding contaminated food. I think it's more essential than treating it. We try, we're doing our best by doing all this detox treatments, but I think it's more effective if the patients from the beginning are not exposing themselves to contaminated food and toxic food.
Okay. So Dr. Smith contributes L-lipoic acid for constipation. It works on chloride channels to stimulate peristalsis and help constipation. So I don't have any experience with that. I don't know if you do, or Dr. Smith, if you're there, can you
this is Dr. Patel, and I have tried that, and I have not noticed the great improvement. I give for many other reasons, but I have not seen great improvement in constipation. If it occurs, it occurs, because we also give magnesium to these patients. So,
right.
Yeah.
But it's something good to keep your eyes on.
Well, alpha-lipoic acid is like NAC, and so it's a detox. But really, it depends on what causes the constipation. So we don't want to generalize treatment for constipation and start just throwing things and say, you know, like the case that I have, he used all kind of constipation treatment and it's not working. And the reason, because the patient has hypothyroid, and that needs to be fixed. So looking for the cause of constipation, if it's irritable bowel syndrome, then we need to work on that. If it's autonomic neuropathy, you need to find out the cause and try to manage it. But finding out the root cause and then go from there and personalize your treatment, I think it's the best way of doing it. But, you know, alpha-lipoic acid and NAC are the same thing. They're thiols, and they are free radical scavengers, and they are detoxing, yes. But again, personalizing your treatment as much as you can based on the lab.
Question, what is the downside of Armour again?
Armour is not reliable, does not give you the level of the thyroxine you need it most of the time. And also, according to not just me, but even Dr. Mike Beamer was a pharmacist, the extraction and the way they're processing it and getting it from the pigs, because it's a desiccated thyroid glands of the pigs. They dry them and then they extract it. Most of the time they get contaminated with other toxins, and they're not giving reliable enough of thyroxine that you can depend on it. I mean, there are some articles about it may induce thyroiditis, maybe by the tissue itself of the pig is similar to the humans, and taking it may trigger that, but we don't have evidence for that. But I will not recommend armored thyroid and hypothyroidism. I will recommend giving levothyroxine and making sure you are stabilizing your thyroxine level. Unless you have some experience of giving this amount of armored thyroid and it's stabilizing a thyroxine. According to the patient that I was managing, he was relying on armored thyroid and not on levothyroxine, and he ended up with chronic constipation for almost years and years. So I don't want to really give that recommendation again.
So those of us who have been around a while, remember armored thyroid is very different from what it used to be. I think it was around 2011 or 2012. It disappeared for about 6 months. It used to be a little soft gel that we had the patients put it under in their gum and it would dissolve. And it was gone for about 6 months. And when it came back, it was a hard shell and it didn't dissolve. And what happened was the company that owned armored thyroid had sold it to a big pharma company, and they changed the coating. And the coating now had, and after about 6 months, our patients, oh great, we have armor back again, but it wasn't the same. And apparently there was gluten and dairy in the new coating of the armored thyroid. So it changed the dynamic, because those are two of the triggers for autoimmune, food sensitivity issues. So that's one thing. The one that I used to like a lot was Nature-Throid, because that also had calcitonin and magnesium in it, which is also produced by the thyroid, which none of the other thyroids, natural or synthetic, contain. But that's been off the market for quite a while now. The company has made it the raw materials available to a number of compounding pharmacies, so you can get it that way. But I don't know what the cost is. There's another one called NP Thyroid, which is a little bit cleaner, and we've used that. And again, these are all T3. If you're not familiar with them, these are all T3, T4 combinations in the exact ratio that we make them ourselves. These were the thyroids that were available before there was Synthroid, before there was levothyroxine. Levothyroxine works well probably in about 60 to 70% of patients, but that leaves a lot of people where they don't feel well on it. And some of them do quite a bit better on the natural thyroids. There's also liothyronine, which is just T3. And you can use that it comes in 5 microgram doses, 5, 25, and 50, I think. You have to be a little bit careful with that. There's a tendency for patients to have palpitations, and if they have heart issues or irregular heartbeats, they can set them off into atrial fibrillation. But we've used that also. We've used it as a synthetic, I call it a synthetic natural. We use levothyroxine and liothyronine, and it should be in about a 4-to-1 ratio. That's the way we make it naturally. If you want to split hairs, it's 78.2% of T4 to 21.8% T3, and we've used those combinations also. Next question: any research on sauna use as a treatment?
What is that, sauna?
Sauna. It just says sauna use, so I don't know. Infrared sauna, I guess. I'm guessing.
Right. Well, if sauna and infrared and all that helps the inflammation, in your thyroid, that's part of the management is to manage the thyroiditis, not just give them like levothyroxine. That makes you different from the mainstream medicine, where they give them levothyroxine and go home, and then that inflammation of thyroid develops into papillary carcinoma and patient dies. So all those treatment that you're doing, ozone and oxidative treatment, or called redox treatment, it's good. Light therapy is redox treatment. It's good for the inflammation.
Okay. Dr. Richwein, just a statement. He's used armored thyroid for years for patients with proper TSH, regulated thyroxine, and who had low T3 syndrome. and persistent symptoms of low thyroid. So that was just a statement.
Mm-hmm. Now, let me add something here. If you have a patient with low T3, normal T4, and normal TSH, don't give patient thyroxine or T3. What's happening to this patient, they have problem with conversion of T4 to T3. And most of the time, it's caused by oxidative stress. So how we manage it, give them NAC, give them polyphenols, try to manage the oxidative stress that's inhibiting the enzyme, iodinase enzyme. And once you restore that, then you will see that T3 goes up. Because if you give them T3, it makes things more worse because it will increase the sympathetic activities and cause more inflammation and more decrease in the T3. And they don't get good results. The patient feel horrible giving them T3. So if you see T3 low, T4 normal, and TSH is high, or T4 is a little bit high and TSH normal, that's because of oxidative stress inhibiting iodinase enzyme, and work on decreasing the inflammation. Do your anti-inflammatory treatments, which is the polyphenols, the light therapy if you want, the oxygen, all that stuff, and optimize all the health, including the metabolic redox and immune, and that will restore the T3, and you don't need to give it to the patient.
Okay. Can Hashimoto's patients take cilantro, L-lipoic acid, magnesium hydroxide, quercetin, resveratrol, or lectins?
All those polyphenols, yes, it's part of decreasing the inflammation. So I think that's part of it. That makes you distinguish you from the mainstream medicine, because you are trying to save the thyroid from ending up into papillary carcinoma or cancer.
Okay. What about chlorella for Hashimoto's?
I mean, chlorella is anti-inflammatory, so I think it's a good thing. If anybody has, I want people here to, this is for verifications. The reason why we have these meetings, I don't want you to be saying, yes, sir. I want people to come say, oh, no, I have different opinions. And this is what's happening. We want to learn from each other here. So if anybody has objections, please come up and say yes so we can learn. Because this is called peer review meeting. This is how we take those information and start applying it on our patients. But after it's been verified by how many doctors? 18 doctors.
Yeah, we had 25 at our peak.
Right. No, but I want doctors here to verify and review and be critical so we can learn from you.
Dr. Halasa, you did not mention anything about selenium.
Selenium is very powerful antioxidants. I mean, yes. I mean, I'm talking selenium. Yes, it's part of. I would definitely recommend it strongly, especially if they have deficiency or just extra thing. Especially we as integrative doctors or CDP, MCS, or whatever you call them, we do a lot of detoxing. And when you do detoxing, you're also washing up good minerals, and we need to work on replenish them as much as we can.
Dr. Fishbein states pancreatic enzymes are quite helpful for constipation. And Dr. Smith is wondering about using BPC either orally or as an injectable for constipation.
Right. It's all personalized. Find out exactly what caused the constipations. And if you feel that there is some decrease in pancreatic enzymes for any reason, then yes. But I don't think that mass giving all the supplements, because it's going to be very costly for the patients. So as long as personalize it and you think the patient needs it because of, and you have reason for giving it, yes. That's what I think. We need to reason anything we give and not just giving it just for the hell of shooting in the dark.
Okay. And Dr. Fishbein states that L-lipoic acid is contraindicated in Europe for Hashimoto's. So there you go.
Okay. But again, we need to know why, because alpha-lipoic acid is like NAC, it's thiol. So we need to know the explanation. So it's contraindication in Europe. I wish if you can learn why from your investigations, and then you come here and tell us why. so that we will be more convinced, and we will definitely put it in a ban list, and we will adjust our protocols.
Okay, so, okay, any questions about anything else?
Well, yeah, can you ask only the question on thyroid or something you discussed yesterday?
You can ask any, Dr. Patel, you can ask anything.
Okay, so here I received a call from another practitioner. This 37 years old male, he had a problem with the muscle weakness, who is or not getting the optimal response to the high level of his exercise and workout. Okay, and so she did the testosterone level, and testosterone level was in high 200. So she put him on 25 milligram of transdermal testosterone. And then I asked about what was his blood count, because many times in alcoholics, then she said that I said, what has brought his testosterone down, or what has been there that has caused? So she told me that this is because he's alcoholic, and okay, and he has a SIBO, and okay, that was the side, and either he has a needle phobia. That was the another thing. So then she was asking me if I would put the pellets. So I asked about the history, because you don't say yes until you know about the patient. And she wanted the testosterone pellets, and I said, no, have you checked his IGF-1? Because if his testosterone is low and his nutrition is poor and other thing we don't know in alcoholics. So IGF-1, and then you discussed yesterday that less than 40 years of age, you don't usually go very aggressive because of the possibility of testicular hypertrophy, not hypo. So then I explained to her that testicle size really goes down after using for a few years. So you have to see. And another patient of mine said it works. The pellets work good for a few weeks, maybe for 4 weeks, 5 weeks, at the most 6 weeks. And then the effect disappears. And the cost is so much for male to have the testosterone pellets. Okay, so then I said, whether have you used Clomid? Have you used DHCG? No. So now my question is, where would you take that from here, or what would be your recommendation if somebody brings to you this type of history?
Well, I will not start giving testosterone. I will definitely check his metabolic panels, including thyroid, because hypothyroidism can cause low testosterone. So I will look on all his metabolic panel, and then his immune panel, redox panel, and check all of that and see if I can optimize as much as I can. And then possibly the thyroxine will kick in and will increase. But if he wants a quick result, and as I said, you said he's less than 40, then if you want to just give him a HCGC while you are investigating all the root cause, at least to decrease in testosterone, which include hypothyroidism, it includes oxidative stress.
That all his workup is negative, but
okay,
he has a hiatal hernia, number 1. And number 2, he does not have a hypochlorhydria. And number 3, that he has a SIBO.
Okay, so all his metabolic panels are normal. Have they done the LH, FSH?
Well, I asked her. She did. I mean, she probably less likely that she did that.
Okay, so after getting that, then I think you would have better picture of, because 6 hormones, we have central and peripheral.
I told her that, I presented for COVID, and COVID, the workup remains the same. But exactly. Yesterday, Dr. Bill, you say that you have tried Clomid. So, what dose, and Can you tell us a little bit more about Clomid?
Clomid is a SARM. It stimulates the testes to produce testosterone rather than using testosterone, which comes in like the blob and shuts everything down. It does not affect the prostate, and it does not affect sperm production. So it works quite nicely for men under 40. It's not quite as effective for older men, but on average, 150 milligram tablet per week, not per day, but per week, will increase total testosterone levels by about 50%. So 2 tablets per week will double your total testosterone level.
So it's not directly stimulating the testosterone production from the testis. It stimulates the luteinizing and follicle hormone release. So it increases central sex hormone release from the pituitary gland. You got my point here?
Yeah.
Yes, yes.
Right. That's the reason doing the LH and FSH and all the estrogen, progesterone, all that stuff. And then based on that, you can give better recommendations.
So then remember that those cases I presented, the effect of COVID and COVID vaccine on the sexual testosterone?
Yeah, and you presented, yes.
Right. So in that, I mean, during the side effects of while patient is having the symptoms, patients LH and FSH usually are not reduced. Okay, so in those patients, the Clomid would not work unless you see that Clomid, the LH and FSH is abnormal, like low. Abnormal means low. It would not work.
Well, even if it's normal, it will work.
If it is normal, it would not work, or it would work.
No, normal will work. Okay, so it still will work if it's normal, but if it's high, then no, it will not work. But if it's normal, it still will work. Low, it will work. Normal will work, but it's high will not work. You got my point?
Yeah. So I told her that you may try Clomid on him, but I just wanted to. Would you give anything? Like he has his estrogen level is high. If his estrogen level is high, and she said he's on anastrozole, so what more can be done for that?
Don't you think the alcoholism and fatty liver and all that stuff is the reason why?
Yeah, that's what I told her. I told her that.
Right.
I say that you give one thing for liver, and then liver that a particular enzyme, and it stimulates, and then that will have a higher turnover.
Right. Have you checked the prolactin for those patients? Prolactin is part of the workup.
She said it was not high. It was not.
Okay, good. Yeah, I think the alcoholism in general leads to fatty liver, and that's the reason they have low testosterone. They perform very bad, those people alcoholic.
He had abnormal liver test, so that means that he had a really absolute liver injury.
Right. So we need to work on that liver, milk, thistle, all that, the NAC, and try to abstain from alcoholic and try to work on the liver. While if he's LH and follicle stimulating is normal or low, you can go ahead with clomiphene, especially with his age. That's what I think. And then just work on his oxidative stress that's leading the problem. Right.
Bill, how much HCG do you give?
HCG.
How much what?
Yeah.
HCG, please. Well, you would use a loading dose, usually around 3,000 units, and then maybe 1,000 to 1,500 units twice a week, sub-Q.
How much you said? 3,000 international units?
3,000 is a loading dose, and then 1,000 to 1,500 twice a week.
Right.
So how many weeks would you try that to see?
That usually comes up fairly quickly. About 4 to 6, you'll get a response.
How long?
Your best bet is the pellets. The pellets, you'll get a response in 4 to 7 days if you use if you get the right dose. I heard you say they gave 35 milligrams of testosterone. Is that what I heard?
Not in a pellets, transdermal.
Oh, okay.
So pellets, what dose would you give to these people?
Usually I start around 1,200, and I've seen it go up all the way to 2,400. You need, we usually chew up about 10 milligrams per day. So that'll tell you how long it should last. 1,200 milligrams should last about.
The strength of the pellet should be what?
What's that?
Strength of the pellet.
12. The average is around 12 to 1,600. We occasionally will go higher. There's some you know, some of the companies that'll teach you how to do it will use really high doses, but I don't like them. We get a lot of side effects from that, doing it that way.
That's if you want to do quick fix, but if you want to do root cause, then also maybe consider DHEA, right? Something that building up the testosterone.
Yeah, at least initially within the first year of testosterone therapy. After that, after the first year, we get there appears to be a negative feedback, and you can get, the more DHEA you get, the lower the levels are. They'll actually drop. You see that probably within 9 months to a year. So it's kind of useless after the first year to give DHEA. You're sort of fighting against yourself. We do use pregnenolone a lot, though. We measure that in every patient.
I do, but I don't know whether, I mean.
How much milligram? 8?
Per pregnenolone? Usually 30 to 60. We can go up to 100, but they usually start at 30 to 60 if they're low. Our sweet spot's about 90 to 110. And,
wow.
Yeah.
Daily?
30 to 60 milligrams a day.
Okay.
Wow.
That's high.
Now,
I mean, I've used.
Can I ask you the question about pellet? You use the 200 milligram pellet, or you use
for males? Yeah, for males.
So then for it, you require at least 6 to 8 pellets, right?
Yeah, usually, yeah, it's about 6 to 8. That's about right.
So does it depend upon what is the patient's starting level of testosterone?
Yeah, you know, blood level, weight. I have a chart which I don't have in the top of my head that we follow.
Yeah, we need that lecture one day with lab, and then from the lab to all this calculation thing. Mm-hmm. That would be nice if we have that lecture.
I think that is the practical lecture then.
Yeah, I like that.
We need now, theoretical lecture has been given, we need practical now.
Well, what we need to do is meet. We need to have an in-person meeting, and I'll teach you all how to do pellets if you don't know how to do it.
Right. No, I do it, but you know, you just need, we need like more friends, supporting friends, so that we can discuss cases.
Right.
So, okay. I think that's about it here. Shouldn't they treat alcoholism with LDN so the testosterone has a chance to possibly improve on its own? Well, I wouldn't treat it alcoholism with LDN. Yeah, you would use full dose naltrexone, not low dose. And I don't know. I don't know if I've ever correlated those two. So anybody else? Any other questions, comments, complaints? I want to know what the Hardings are eating for dinner. So they left their camera on, and they're sitting here watching them eat. So, and you're muted, so you can't hear what you're saying. So, all right. So, John, you got anything for us?
All wonderful stuff. Thank you very much, Dr. Halasa and Bill and Dr. Patel and everyone else.
Okay, next week we have Dr. Prasad. He's going to be talking about nutritional aspects of chronic disease. So it's right up our alley. So we'll be back same time, same station. And I was going to see who's coming after that, but that Dr. Harding here will be coming after that. So on July 12th. So he'll be here in 2 weeks. So and with that, I'm going to say good night. Anybody else have any comments, questions? Anybody wants to present anything, let me know. We always have openings. So let me know. And Dr. Halasa, thank you so much as always.
Thank you for having me.
Thank you. You're our inspiration here. So
thank you, Dr. Halasa.
Okay.
Thank you very much.
Dr. Patel, thank you also.
Thank you. And we want to hear Dr. Patel. She has a lot of experience and skill, like many years.
Right. Okay. We'll have her back. We'll have her on again. Don't worry.
Right. And
Okay,
Dr. Cheryl, she can come up with something too. She used to be doing a lot of COVID. But Dr. Cheryl, she used to be my wife's gynecologist and obstetricist. And she's the well-known doctor in Eastern Maryland and gyne and obstetrics. So,
well, welcome.
If there's anything.
We're happy to have you. If you want to, I don't know if you're on our mailing list. If you are, great. If you're not, let me know. Send us your email and we'll put you on there. Ron, good to see you again. Dr. Smith, thank you. Dr. Harding and Mrs. Dr. Harding, thank you for joining us.
Thank you.
And whoever this phone person is right here, thank you also. I got a phone number. And Marie, of course. Can't leave out Marie. Okay, so we're going to say goodnight. We'll see you next week, same time, same station. And thanks everybody. Over and out.
Thank you.